So today we are going to discuss about one of the most important growth theories, that is the functional matrix theory. The functional matrix theory is based on that the one function, that is example is swallowing. The functional matrix theory is based on proposed by Melvin Moss, is that one function will have a functional cranial component, and that will in turn have a functional matrix, in turn has a skeletal unit within it, and the most important part of growth is primary, which is the functional matrix, and the growth of the skeletal structures is secondary. The functional matrix consists of the periosteal matrices and the capsular matrices, which have got microskeletal and macroskeletal features. Now the periosteal matrix consists of the muscles which have a very good active growth in them, that is deposition and resorption affect the size and the shape of that particular structures. Now coming to the capsular matrix, that is the functioning spaces, that means the brain, the oral cavity, the orofacial capsule, the neurofacial capsule, and this exhibits passive growth. There is active growth in the periosteal matrices, there is passive growth in the capsular matrices. The periosteal growth of the skeletal growth in the skeletal structures is secondary to the functional matrix. Now the periosteal matrix, the tissues act directly on the related skeletal units, thereby bringing about a transformation in their size and shape. This transformation, due to the action of periosteal matrices, is brought about by bone deposition and resorption. This process of bone deposition and resorption is called as bone remodeling. Now capsular matrix, the growth in the capsular matrix is a very passive system, act indirectly passively on the related structures. The facial skeletal units are passively and secondarily moved in space as the enveloping capsule is expanded. Like example, the growth of the brain size, the growth of the oral cavity size. This is the capsular matrix. The growth is very passive and cannot be appreciated. This kind of translative growth is not brought about by deposition and resorption. Deposition and resorption, the growth is in the periosteal structures. Now active growth and the passive growth contribute to the total growth. That means the growth in the periosteal structures, the growth in the capsular structures contribute to the growth. Now coming to the craniofacial skeleton or the craniofacial growth, the active growth processes occurs. The active growth is at the sutural level. The active growth is by bone remodeling, that is your deposition and resorption, and there is cartilaginous, wherever there is a cartilage, there is cartilage growth. Then you have your passive growth processes. That the passive growth process, the growth of the neural, orbital, the cerebrospinal fluid and other masses and the real substances. The expansion of the orofacial, the pharyngeal spaces is all passive. These are the passive growth process in the craniofacial skeleton. Coming to the Van Limbach theory, all the popular theories were not satisfactory but contain elements of significance. So the 5 factors according to the Van Limbach theory are the intrinsic genetic factors, the extrinsic genetic factors, the local epigenetic factors, the general epigenetic factors, the local environmental factors, and your general environmental factors. Now this is how the craniofacial bone formation, the orthotypic bone development constitutes the endochondral ossification and the intramembranous ossification. And also you have the heterotypic bone development, wherein you have the fibroblasts into the osteocyte, that is the tendon, and the chondroid bones. And this slide shows about the endochondral ossification of all the long bones, including the mandible. This is the endochondral ossification structures, which can be detailedly read in all the histology textbooks. Now the next endochondral means within the chondra, within the cartilage, the ossification happens. This happens with the long bone. These long bones have 2 heads on both the sides. A mandible is also shaped into 2 heads. The 2 heads are the heads of the condyle. And coming to the intramembranous ossification, there is a membrane. All the flat bones, there is an intramembranous ossification. So for example, the head, all the flat bones are intramembranous. intramembranous ossification. This is the development of the head and neck. This is the embryonic stages at 5.5 weeks, 6 weeks of the embryo in the mother's womb, 7 weeks into the embryo, and 8 weeks into the embryo. You can see the phase is getting developed here. You can see the phase is at 8 weeks of intrauterine life. This is 8th week of intrauterine life. You can see proper shape of the head being formed. There are various parts of it, the timings, then the components, what are all developed, the brain development, the neurogenic placodes, the pharyngeal grooves or the pouches, the pharyngeal arches, each give rise or constitutes to a wonderful anatomy that grows into a big human being. Development of the phase starts at 4th week of intrauterine life with the embryonic swellings. External phase is completed by 6 to 8 weeks. The internal development, the hard palatal development and all at 6th to 8th or 9th week. Soft palate is completed by 12th week of intrauterine life. Now coming to certain terms called as drift at displacement. Now what is cortical drift? A combination of bone deposition and resorption resulting in a growth movement towards the depositing surface is called as cortical drift. Now it can be classically demonstrated in this way. The red arrow indicates the drift, the green arrow indicates the displacement. There is plus means deposition of bone, minus indicates the resorption of bone. There is deposition, there is resorption. The drift is happening towards the depositing surface. The drift is happening towards the depositing surface. The displacement is happening towards the resorptive surface of any bone. This is quite common in any growth of any kind of craniofacial skeleton or all bones together. Drift and displacement. Now coming to the 8th week intrauterine embryonic stage, and this is the 12th week the embryo. This is the 8th week, this is the 12th week. Here you can see a classic difference between the endochondral ossification bones and intramembranous ossification bones. So this is a pioneer in studying, he is Enloe. He has given a lot of concepts on the growth of the craniofacial skeleton, especially the V growth principle, Enloe's expanding V principle, Enloe's counterpart principle, and many other principles. And he has written a beautiful textbook, Essentials of Facial Growth by Enloe and Hans. This is a wonderful textbook which gives you a lot of information about how the craniofacial skeleton grows, and there are various principles, V principle, counterpart principles, and many other principles. So coming to the most important for an undergraduate student is Enloe's expanding V principle. What does it constitute? Any kind of a bone which is in the shape of a V, and most of the bones are like the maxilla, the mandible, all are in shape of the V. There is deposition and resorption. There is deposition of bone, there is resorption of bone. Now where does the growth direction? Growth direction is always towards the opening of the V. The growth direction is always towards the opening of the V. This is the opening of the V in the maxilla. This is the opening of the V, and deposition on the inner surface, resorption on the outer surface. So growth direction is towards the opening of the V. Depositing on the deposition, the plus marks deposition on the inner surface, resorption on the outer surface of the V. Most of the craniofacial structures, the mandible, the maxilla, the zygoma, the other skeletal structures all have this and follow this principle of Enloe's expanding V principle, that is deposition on the inner aspect, resorption on the outer aspects, making it wider and wider as we grow. As we grow, the bones become wider and wider, and the spaces become wider and wider. So Enloe's growth direction is always towards the opening of the V. This is a classic diagram to be drawn in your undergraduate exam papers. And these are this slide shows you the various cartilages which are existing as the growth centers or growth sites. The growth sites in the craniofacial skeleton. Now, where is the level of growth control? Is it in the sutures, is it in the cartilage, or is it in some other places? That determines the growth theories. Now, functional matrix theory, earlier to that, there were other theories, genetic theory, the cartilaginous theory, the sutural theory. All these theories are good at their own perspective level and the knowledge at that particular time when they were postulated. Now, which are the areas that control growth? The areas that control growth is determines whether it is called a growth site or a growth center. What is a growth site? Wherever growth happens, it is a growth site. Distinguishing between a site and center of growth clarifies the differences between the theories of growth control. So, theories of growth control. So, earlier days they were thinking that wherever there is sutures, the growth happens. So, suture is the most important thing. But when as the knowledge of growth increased, so slowly it shifted to cartilage is an important structure. But Melvin Moss has given an amazing theory, that is the functional matrix theory, which we discussed in the earlier slides, shows that the functional matrix is the most important structure rather than the function, and the functional matrix structures are most important than cartilage or suture. The cartilage and suture, yes, growth happens, that is a growth site. This is the growth site. A site of growth is merely a location at which growth occurs. It's merely a location at which the growth occurs, whereas a growth center is a location at which independent, genetically controlled growth occurs. This is called growth center. Now, all centers of growth are sites, but the reverse is not true. Reverse is not true. Now, coming to all these structures where growth happens in the craniofacial structures, one is at the sutural level, two at the maxillary tuberosity level, mandibular condyle, yes, growth happens because of the condylar cartilage, posterior border of the mandibular ramus, dentoalveolar process, synchondrosis of the basic cranium. There are small cartilaginous structures in the base of the cranium. They are called as synchondrosis. Two-way bidirectional growth happens in the synchondrosis. There are nasal cartilages as well. These are all growth sites. These are all growth sites in the craniofacial skeleton. The sutures, the tuberosity, the mandibular condylar area because of the condylar cartilage, posterior border of the mandibular ramus, the dentoalveolar process which holds the teeth because the teeth are slowly erupting into the oral cavity, the deciduous teeth and the permanent teeth, when they erupt, they grow the surrounding structures as well. Nasal cartilages. Cartilage is a site of growth. Now, all the sutures between the bones of the skull are cranial sutures. Now, cranial sutures, there are so many, the lambdoid, the parietal, the lambdoid suture between the parietal and the Womerian bone, the frontal sutures, mid-parietal sutures, these are sites of growth. And definitely growth happens because there is a lot of potential bone cells at the sutural level. Now, the growth of the cranial vault. Now, coming to the growth of the cranial vault. Vault is something on the roof. Vault. The cranial vault and the cranial base in the orbit is almost complete by 7 to 9 years of age. Because the brain size is done by 7 to 9 years of age. So, the cranial vault, the cranial base in the orbit is almost complete by 7 years. The nasal region, the nasal region is completed by 10 years. The size and shape. The maxillary region 15 years, the mandible 20 years. So, this slide gives you an idea of the general rules are the increase in size, change in proportion and the adjustment in position. This is what happens during the growth. After the size and shape are attained, now the external factors also contribute, the internal factors and the external factors also contribute to the minor remodifications which happens that can be utilized by the professional of orthodontics in advancing the mandible, sometimes giving orthopedic appliances and so on and so forth. This is due to the growth velocity change and differential growth. The growth doesn't happen in a day, growth doesn't happen in a week, growth happens over a period of time. There is a spurt of growth. That spurts of growth is called growth spurts. Growth has happened 4 times in life. One is just before birth, 1 year after birth, prepubertal growth spurt, pubertal growth spurt. There is a spurt, there is a sudden activity of growth. These are the 4 phases. After that is that the growth is very slow and very adaptive in condition. So the face reaches the adult size in order of facial width. The facial width is found first. The facial depth is the anteroposterior and the facial height. So this is in the order. First finished is the width, then finished is your anteroposterior, the depth, then is the height of the face. The height of the face is the last thing that is formed. The width is first thing that is completed, the width of the face. Now depth, the depth is your anterior posterior, this is the depth, the facial depth. The face reaches the adult, since there is variation in velocity, the proportions of the face changes with ages. Facial growth curve lies between the neural and the somatic curves. We have in the earlier classes we were discussing about the growth curves. What are the growth curves? The somatic growth curve, the general growth curve, the lymphatic tissues growth curve. The lymphatic tissues growth curve is like this and comes down, falls to the 100% level. When the child is at 7 years of age, all the lymphoid tissues such as the adenoids grow double to the size, because to avoid infections. So yeah, the velocity and the proportion of the tissues also varies according to the growth spurt. Coming to the growth of the head, these are the sutures which we were discussing. Cranial vault. See, the vault is growing because the sutures are widening. When the sutures wide, the size of the brain is increasing. The size of the brain is increasing. It pushes these sutures to grow further. This happens by the end of 6 to 7 years of age. Now, growth of the cranial vault is made possible by the differential growth at the sutures in response to the growth of the brain. Now what happens that was the outer aspect, this is coming to the inner aspect of the cranial vault. What is happening here? All the minus, the base of the skull, that is resorptive in nature. The base of the skull is resorptive in nature. Base of the skull is resorptive in nature. Here there is deposition on the inner aspect. Internal part of the cranial vault is depository. Resorptive in the cranial floor here. The external part of the cranial vault is depository. Now coming to this picture, this has a dark pencil and a lighter pencil. All the areas in the darker shade shows a resorption of bones, showing the brain development downwards. So the only part which is wider, the petrous part of the temporal bone and the ethmoid, cribriform plate of the ethmoid, is depository in nature. Depository, there is addition of bone as the person grows. Cribriform plate and your petrous part of the temporal bone. These are depository in nature. The others are all resorptive in nature. So a distribution of resorptive and depository periosteal surfaces in the cranial floor. Resorptive regions are shown in the black and depository areas in grey. So what happens as a result? Increase of the cranial height due to resorption of the cranial floor, except that the petrous part of the temporal bone. There are important structures here. Now we are going to the cranial base. Now what is the most important structure in the cranial base? The cranial base is a wonderful bidirectional growing cartilaginous substances at 3-4 regions. They are called as synchondroses of the cranial bone. This picture shows you the bidirectional nature of the growth happening. This is the cartilage which is growing in bidirections, making the anterior cranial fossa, middle cranial fossa and the posterior cranial fossa. There is a sphenoethmoid, there is an intersphenoid, there is a spheno-occipital. So 3 growth sites at the cranial base. The 3 growth sites are the sphenoethmoidal, intersphenoidal, spheno-occipital synchondroses. These are the 3 synchondroses. The growth of the synchondroses is always bidirectional, as said earlier. So intersphenoid, when does it fuse? It fuses at birth. By the time the person is born, the intersphenoid suture, the intersphenoid is fused. So coming to the sphenoethmoidal, it fuses at 7 years of age. The last to fuse is the spheno-occipital at around 25 years of age. Now what does the significance of sphenoethmoid, the fusion of the sphenoethmoid by 7 years of age? The result is the anterior cranial base almost is completed by around 7 years of age. Spheno-occipital is fused by around 18 to 25 years of age. That is your posterior cranial base. Posterior cranial base. The posterior cranial base will still grow into adulthood in response to the sphenoidal sinus expansion. Now we'll discuss the nasomaxillary complex and the nasal bone in the next class. Thank you very much.